You are welcome to Nursing 341 High Risk Neonate. For the purpose of this session, I want us to have an overview so that you have a firm grasp of what it entails when we talk about the high risk neonate. I am Ms. Samira Ali Mustafa, and you can see on the slide my email address. And for the purpose of this class, we have to have some ground rules. 1, in some of the sessions, as much as possible, I've given you some assignments to do. Please do take time to try your hands at them. Secondly, you are also required to view some videos on Sakai, and also give me any concerns you have on the Sakai platform. That is where we'll have most of our deliberations, and not through my email. Okay, so let's start rolling. The session overview. The high-risk neonate, by definition, is a newborn regardless of gestational age who has greater than average chance of morbidity and mortality because of the conditions or circumstances associated with the birth. So note that the high-risk neonate has the risk of morbidity or mortality. And the high-risk period extends from the period of viability in utero. That is, in Ghana, we will say that above around 34 weeks, when the newborn comes out around this time, or when the fetus is born, it survives. But international standards is around 23 weeks. So it's important that you know that in other parts of the world, an infant or a newborn or a premature new baby at 23 weeks survives. So by international definition, this is 23 weeks in high resource countries, up to the 28 days following the birth. So it's important to know that this period extends from prenatal, perinatal, and postnatal period. And then high risk period is the first 28 days, and that is what we call the neonatal period. This session seeks to introduce students to various classifications and common problems and therapeutic management. The goal for this session, or our objectives, is that at the end of this session, each one of you students will be able to define the high-risk newborn, identify various classifications of the high-risk newborn, mention common problems of the high-risk newborn, and describe the therapeutic management, and perform a physical assessment. So for today's discussion, some of the key topics we'll be discussing are the high-risk newborn, risk factors of the high-risk newborn or neonate, and then classifications, as I've said, common problems, and therapeutic management. For your reading, we will also upload the textbook, The Wong's Essentials of Pediatrics Nursing by Hockenberry and Wilson. And it is also available online, which you can have or download for yourselves. Who is a high-risk neonate? We are saying that it is an infant who is susceptible to morbidity, that is illness, or even death, because it is dismature, immature, or have some physical complications during birth or after birth. And this could have started in utero. So that is the essence of antenatal care. When the mother comes to you and is assessed, you will see that sometimes the abdominal girth may not be increasing, or the mother may not be gaining weight, or the mother may have some conditions that may predispose the newborn to illness or even death. So when you suspect, I want to emphasize that the high-risk neonate is not sick per se, but it is something that you anticipate and then prepare adequately for the delivery. Therefore, such a newborn should not be born in the private maternity home or even the community like the polyclinics, or a CHIPS compound. But such a mother who we anticipate that is likely to give birth to a high-risk newborn should be referred to a regional hospital or a national hospital that is well equipped in terms of resources to adequately deliver this child safely and give it all the necessary support to reduce the risk of morbidity and mortality. So we ask ourselves, which babies fall in this category? It's important to note that a baby that is small for gestational age, a large for gestational age newborn, the infant of the diabetic mother, the post-term newborn, the preterm newborn, the newborn of the HIV positive mother, the newborn with various congenital anomalies, especially cardiac, and more are exposed or categorized or considered high-risk newborns. What is the goal of our care when it comes to taking care of high-risk newborn? We want to prevent perinatal morbidity and mortality. And also, we want to resuscitate and stabilize and support the care and the health of the newborn. And then continuously evaluate and manage the newborn. And this takes frequent monitoring. And this will make a lot of difference. And then in our care, when you are dealing with the newborn, you are dealing with the family. So family-centered. You want to involve the parents and any other significant other and involve them in decision-making. And we talk about strength-based care, where you are looking at the strengths available. What do the people have that we can use to support their care? So if the mother is sick, can the grandmother come to support one way or the other? Whatever you think is a strength in terms of caring for the newborn and the family, you consider that and work with it appropriately. It is also very important that we look at some risk factors, and this can be low socioeconomic status. We know that this is associated with poor nutrition, and also because it may also be associated with poor accommodation. So we know that if the pregnant woman does not eat well, she is likely to suffer anemia or may not be able to afford care. If she's hypertensive, she may not be able to afford her medications, and therefore we predispose her to having a high-risk newborn. And then also we're talking about environmental dangers in terms of radiations out there that will also negatively impact the fetus. Obstetric factors in terms of age, if the woman is above 35 years, is also a source of danger. If she's had more than 3-4 babies, we call that high parity. And then she's also at risk of mature deliveries when she has incompetent service and the like. And then certain medical conditions like hypertension, or in cases where the pregnancy induces the hypertension, or the mother ruptures membrane more than 18 hours before the delivery. It predisposes her to infection, and this also passes through the placental barrier, and the baby can be born with sepsis. So we have to ask ourselves, when we talk about the high-risk neonates, which category of babies are affected? It's important to note that the preterm, the term, and the post-term, that is to say, all categories of babies can become high risk. And also, it is important to know that an infant, whether a newborn, whether preterm, term, or post-term, can also be large for gestational age, average for gestational age, or small for gestational age. The newborn will be said to be large for gestational age if the birth weight exceeds the 9th centile on the growth chart, and average when it's within the 50% and small when it's below the 10th centile. So what is the relevance of having or discussing the high-risk neonates? It helps us to anticipate and plan appropriately, as I said, and therefore refer early and help to deliver the baby safe and sound, and also help us in monitoring the baby. So at birth, we have something we call ABGA scoring, where you assess the baby quickly and make your impression, and also give the appropriate care to support life. Once again, it's important to know that constant observation is key. Wherever you find yourself and you are dealing with it, also improve their chance of survival. Okay, it's also very important that we consider the fact that according to gestational age, the baby can be classified according to gestational age, according to mortality, and then their weight. And all these things may be related to dysmaturity, physiological factors, infections, maternal conditions, and congenital anomalies, which I've already explained. So let's look at what goes into the categorization or classification according to gestational age. Here we ask ourselves or define who a preterm infant is. The preterm infant is the newborn who is delivered before 37 completed weeks of gestation. That is 259 days. So by this definition, you know that then the child is born before 37 completed weeks. So any weeks below 37, that is 36 and below. And I'm saying that in Ghana, when the newborn comes around 34 to 36 weeks, they tend to survive. But when we talk about international standards of dealing with 28 weeks, they have challenges because we don't have the high-tech equipment to facilitate and support their care. And then the term infant is born at or after 37 weeks, completed weeks of pregnancy, counting from the last menstrual period of the mother. So it's important to note that this period extends between 38 weeks to 42 weeks of pregnancy. That is term, and that is the normal newborn. And then post-term is after the beginning of the 42nd week of pregnancy. So you see that sometimes when the baby comes around this period, then the baby might have outstayed its welcome, and then we may have problem with the placenta degenerating and also leading to some problems of hypoxia and the like. So when we talk about the newborn according to weight, then we are looking at the low birth weight, where the weight is below 2,500 grams, or very low birth weight when it is less than 1,500, and then extremely low birth weight when it is also under 1,000 grams. So I want us to look at classification according to maternal conditions when the mother either has diabetes, anemia, or any other condition that will affect the fetus growth and development. And then classification according to mortality. This, we talk about the live birth, the fetal death, the neonatal death, and perinatal death. This informs our demographics and also help us to know around which time we are having these instances and therefore plan adequately to receive them. And when these newborns come out, we talk about assessment at birth, the ABGA scoring. ABGA scoring look at the appearance in terms of color, the pulse, the heart rate, the muscle activity or tone, and then the respiration. When it is 0, then when these are absent or the color is blue, so the baby is cyanotic, the score is 0. And then above that, is 1. And then when it's very active, the baby's whole body, including the extremities, are pink. It has that. And so I'll refer you to read more on APGAR scoring, and note that when the APGAR score is between 4 to 6, then it connotes that the baby is moderately. So in terms of nursing management, our goal is to correct physiological stressful situations, which we'll be discussing, and interpret the laboratory findings. So we'll be looking at certain physiological readings in terms of lab works and what they stand for, and also observe infant energy for healing and growth, and also assist the family in developing attachment with a sick child and involve them in their care. So to summarize, I'm saying that it's very, very important that we check the vitals of the newborn and note that the temperature between 35.5 to 36.5 is hypothermia and will worsen the baby's condition. So as much as possible, we want to maintain a temperature of 36.5 to 37.5. And it also means keeping the baby warm, and then also ensuring that we feed the baby. If the baby is too weak, we also pass NG tube and feed the baby and make sure that the baby is adequately hydrated, and then we monitor the weight gain and loss daily. And also it's very, very important that we monitor the vital signs, and then when there is some problem of respiratory difficulties, it will exhibit by the flaring, grunting, the flaring of the nurse, cyanosis, and some apneic attacks. So it's very important that we note this. This is what time will allow us to discuss, and I think this will help you to have a firm grasp of what it takes to discuss the high-risk neonate. Thank you.